And today I have made efforts to appear before you as you can connect with me more. And head and neck is considered a difficult chapter, so I decided to teach the chapter by writing, not by the PDFs, because I feel that the PDFs are a bit boring, or you can't just correlate with the things. And this chapter will do by writing. I will cover the main concepts that are present in that are given in the head and neck. Then we'll go to neuro. So let's see if it can be done in one video, or it can be like made multiple videos and all. We'll see, but we'll cover in the shortest possible time that is helpful for you. And as your props are there, so it will be helpful for your props as well as your PG as concerned. So let's start the head and neck with our scalp. You know the scalp, the basic framework of the scalp. Okay. And let's talk about the layers. Let's talk about the nerve supply. Let's talk about the arterial supply. Okay. Let's go into it without much delay. So so first is the scalp. What is the extent of the scalp? It is extending anteriorly from the superciliary arches. It is moving like this posteriorly to the superior nuchal lines, and this lateral side is connected to your superior temporal lines, superciliary arches, superior nuchal line, and the superior temporal lines. So this is the extent of the skull. And talking about the layers, what are the layers? So you can remember by this. That's first layer is the S. S is the skin. So this is the skin. Then the second layer. Second layer is C. C is your connective tissue. Let's draw the connective tissue. Connective tissue, and this is a dense fibrous connective tissue, dense fibrous type. And the skin of the scalp is generally thick and hairy, and it has sebaceous glands present. So we can say that the scalp is a major site of the sebaceous cyst. Okay, sebaceous cysts are occurring here. It's the site of your sebaceous cysts in your scalp. And after connective tissue, we have a next layer, that is A. A is your aponeurosis. Let's draw the aponeurosis in green. So this is your aponeurosis. And this aponeurosis of the scalp is attached anteriorly to the frontal belly of occipitofrontalis muscle, and posteriorly to the occipital belly of your occipitofrontalis muscle. So it has a muscle. So it muscle has generally the frontal belly, occipital belly, and in this region, the main region of the scalp, it has the aponeurosis. So generally, it is intrinsically connected to the occipitofrontalis muscle. Understood? Let's talk about the next layer, skin, connective tissue, and aponeurosis is done. Then we have the fourth layer, that is the loose connective tissue. Sorry, loose areolar tissue. So this layer is your loose areolar tissue. It is your loose areolar tissue. Okay, loose areolar tissue. And the last layer, that is your pericranium. Okay, pericranium. So these are your layers of the skull. Some important facts are there. Like I talked about the skin, it is thick, hairy, hairs are present, and it is the site for a sebaceous cyst. Okay, and sebaceous glands are present which secrete the oily sebum, which are responsible for the sebaceous cyst. The second layer, the connective tissue layer, the second layer is called as the dangerous layer of the scalp. It's called as the dangerous layer of the scalp. Why? Because this connective tissue layer, it has emissary veins which are connecting the second layer to the underlying dural venous sinuses. So we have devious here, we have the dural venous sinuses, and some emissary veins are present, which are connecting the connective tissue layer to the dural venous sinuses. And this dural venous sinus, we'll talk more about dural venous sinuses later. So this is helping. Why this? If there's an infection in the connective tissue layer, it can transverse down the dural venous sinuses and cause infection inside your brain. So infections inside the brain are very dangerous. So this second layer is called as your connective. That is the dangerous layer of the scalp. So connective tissue is called as your dangerous layer of scalp. Understood? Done? So that was about talking about the layers of the skull. You must have observed black eye. Black eye. Why it is formed? Because your frontal belly of the occipital frontalis is continuous with the skin, and we have underlying connective tissue. We have the underlying areolar tissue. Okay, this areolar tissue is present inside this aponeurosis. Aponeurosis, that is the frontal belly of your occipital frontalis, and we have the areolar tissue down beneath it. So if there is a head injury, if you there is your this type of injury where there is it depends on how the dashboard injuries are there. If the car dashboard is there and you just hit your head and bleeding occurs. If there is much bleeding, this bleeding will localize. This bleeding will go down your areolar tissue layer. It will go down your areolar tissue layer and accumulate in your orbits. So you can have black eye. So black eye is due to this, and this loose areolar tissue layer, this fourth layer, this loose areolar tissue layer, it is sort of important layer. It is a important in the sense it first of all loose areolar tissue is there, so it is providing a cushioning. It is providing a cushioning, and it prevents the infection. It causes a phenomenon which is called as safety valve hematoma. It forms a phenomenon which is called as a safety valve hematoma. So, what is the safety valve hematoma? Is that if there is a bleeding, if there are injuries, okay, if there is any bleeding which gonna compress our brain, so, okay, we don't need any injury inside our cranium. Okay, we don't need any injury because it will like damage all your intrinsic functions of all the functions of the brain. If there is even a slightest cerebral compression, it can cause the widespread damage to the brain. So we don't need that. So what we have is your loose areolar tissue, and this loose areolar tissue, it can condition the bleeding. It can have the bleeding inside it only. It can have the bleeding inside it only. So it is in newborn, in children, this head injuries are common. Like they hit the head somewhere, they do like widespread things. So loose areolar tissue layer is generally preventing the bleedings to compress your cerebral vault, and just preventing the things that is to compress the brain or so. So it is acting as a safety valve hematoma. Safety valve hematoma. This phenomenon is called as a safety valve hematoma. Okay. Let's discuss some other things about the scalp. The blood supply, nerve supply. These are common things. So let's discuss this. Talking about the nerve supply of the. Okay, so we are seeing the scalp from the superior view. Superior view. Let's say here is a nose, and ear is there here. Done. So what is the nerves that? What are the nerves that are supplying the scalp? So if we divide it in this part, what are the nerves that are coming? So first of all, we have our. Just let me make the nerves, then I will label it. Then we will have from here, here, nerve from here. Done. So these are your nerves that are supplying the scalp. Let me label this. The first one is supratrochlear nerve. Your supratrochlear nerve. The second one is supraorbital nerve. Supraorbital nerve. And just remember that this both nerves are the branch of a V1 nerve. V1 nerve. That is a ophthalmic nerve. Ophthalmic nerve. And the this one is called as a zygomaticotemporal nerve. Which is a branch of a V2 nerve. V2 nerve is a maxillary nerve, and this one is called as a auriculotemporal nerve. Auriculotemporal, very important nerve. It gives a passageway to the middle meningeal artery, and this damage to the auriculotemporal nerve will cause a Fraze syndrome. This damage will cause your syndrome. Fraze syndrome, what happens? If there is any salivary stimuli, if there is an oral salivary stimuli, or if there is any smell of food that is occurring, the patient will start sweating. the patient will the skin will start flushing, and the patient will start sweating, and this is due to a degeneration process which is called as the Valerian degeneration. Due to this, what happens is the fibers which are there for salivation, this grow into the fibers that are for lacrimation. The fibers of salivation, this grow like there is a Valerian degeneration of the lacrimal fibers. Okay, lacrimal fibers are Valerianly degenerated. Okay, orthograde degeneration or Valerian degeneration, you must have read in the physiology. So what happens when they regenerate, when they start regenerating, sometimes it may happen that the lacrimal fibers may grow mistakenly into not your lacrimal fiber, the fibers for your that sweating. Okay, they grow mistakenly into a salivary fiber. So if there is any salivary stimuli, the patient will start sweating. Understood? So this is your phrase syndrome. This is your phrase syndrome. And talking about another these nerves, which are your great auricular great auricular nerve, root value is C2 to C3. Then we have our lesser occipital nerve, root value is C2, lesser occipital nerve, root value is C2. We'll see the cervical plexus in while when we talk about all the root values, how they are coming. So cervical plexus is called as a loop, the plexus of loops. There are many loops present in the cervical plexus. So how these nerves are coming, how the loop is forming, we'll see. We'll see in a very simplified manner. So let me first finish up this. Lesser occipital nerve, then we have the greater occipital nerve. Root value is again C2, and then your third occipital nerve, and root value is C3. So that completes the nerve supply of the scalp. Let's discuss the blood supply of the scalp then. Okay. So after completing the nerve supply, let's go to the blood supply of the scalp. Let me draw the scalp again. Yes. We have a nose here from superior view, the auricles here. Okay. Let's discuss this. First of all, we had the supratrochlear nerve and the supraorbital nerve, right? In the nerves. So here we have a supratrochlear artery. Supratrochlear artery. Just don't write ST, will be confused with the superficial temporal artery. So I'm just labeling the your supratrochlear artery, and then we have our supraorbital artery. Then these are your arteries. Then what? Then another artery. What is the another artery? Here we'll have our superficial temporal artery. Superficial temporal artery. Understood? Superficial temporal artery. Then afterwards, what artery we have? We have our posterior auricular artery. We have our posterior auricular artery, and at last in the occipital side we have our occipital artery. We have our occipital artery. So that completes. You can see that it is supplied by 5 arteries. So the bleedings of the scalp, it bleeds profusely. There is profuse bleeding in the scalp. Okay, because there are about 5 arteries in one side, 5 arteries in the other side. We have 10 arteries, combinedly 10 arteries in one place. So you can imagine how much will be the that if there is an internal hemorrhage or so, there will be complete. There will be injuries of scalp bleed profusely. Okay, which is a clinical fact which I told just. So that completes your scalp. That completes your scalp. Let's move on to our next concepts of the head and neck. Let's get on to the next concepts. Let's move on. So let's talk about our cervical plexus. Okay. Let's move on to the next concept, that is your cervical plexus. Let's talk about the cervical plexus. So all the plexuses, they form from a ventral rami, okay, ventral primary rami. So cervical plexus is comprising of ventral primary rami of C1 to C4 segments, and the deep branches. We'll see about superficial branches and deep branches. In the deep branches, we will also see the involvement of the C5 in a phrenic nerve part. Okay, So cervical plexus, and it is also called the plexus of loops. As I told earlier, it is also called as the plexus of loops. It has many loops are present. Many loops are present. C2, C3, C3, C4. This many loops are present. So it is called the plexus of loops. So what happens? Cervical plexus, when it is given in a book, and the superficial and deep branches are just combined, so it becomes very complex to understand. So what we are gonna do is we'll learn about superficial branches first. We'll talk about the deep branches later on. Okay. So we'll first talk about the superficial branches. What are the superficial branches? So let's draw the vertebrae here. C1, C2, C3, C4, and a C5. Done. So first, what we'll do, this is your anterior side. This is the anterior branches will occur, and here your posterior branches will arise. So we will connect your C2 and C3. We'll connect your C2 and C3 and C3 and C4. Connected this, connected this. From the C2 part, let's draw the nerves in your yellow color. From the C2 part, there is nerve will arise, which is called as a lesser occipital nerve. Okay, which will call as a lesser occipital nerve. So yes, where was I? There was a phone call. Let's continue. Yes, so we joined the C2 and C3 segments in the C3 and the C4 segments. After that, there will be nerve arising from the C2 segment, that is your lesser occipital nerve. Okay, so we have the C2 segment arising nerve, which is LO1, lesser occipital nerve. And from the middle of the C2 and C3, from the middle of the C2 and C3, there will be nerve arising. So lesser occipital nerve root value, it's very simple, C2. We talked about this root value in the scalp also, you can see. That's why I discussed the cervical plexus so that you could relate the scalp, C2. Then there will be nerve arising from the C2 and C3 segment, that is called greater and auricular nerve. Root value is C2 to C3. That's Then there will be anterior branch, that is called the transverse cutaneous nerve of neck. From the C2 and C3, well, there will be a nerve that is a transverse cutaneous nerve of neck. TCNN, transverse cutaneous nerve of neck. Done. Then what will happen? Then there will another nerve. Then there will be another nerve arising from this segment, from the C3 and the C4 junction between C3 and C4 segments. This one, and it will divide into three branches. These all are called as your supraclavicular nerves. Supraclavicular nerves. That So these are all your superficial branches that are arising from the cervical plexus. Okay, and root values you can know TCNN. The root value will be C2, C3. Then the supraclavicular nerves. The root value will be again C3 and C4. C3 and C4. Let's talk about the deep branches. Let's talk about the deep branches. Let's talk about the deep branches now. Talking about the deep branches, let's copy and paste the skeleton if it is possible. Or let me pause and make. Okay. So here what we have is that from the C1 segment, from the C1 cervical segment, there will be a nerve arising and supplying two muscles. So there is a nerve arising and supplying two muscles. Okay. And your geniohyoid and the thyrohyoid. So a nerve is arising from C1 and supplying two muscles, that is your geniohyoid and a thyrohyoid. Then what will happen? Then there will be nerve arising from C3, C4, and C5 segments. A nerve will arise. Just try to correlate with the nerve. Yes, phrenic nerve. What is the root value of phrenic nerve? C3, C4, C5. Yes, phrenic. Okay, finished. This is the phrenic nerve. Root value is C3. Just what happened? Wait a minute. Okay. There are some technical glitches. So from C3, C4, and C5, there will be the phrenic nerve, root value C3, C4, and your C5. Then let's talk about another nerves that from the C2 and C3 segment, from the C2 and C3 segments, another nerve will arise, which is called as a descendens cervicalis. This one. It's called the descendens cervicalis. Descendens cervicalis. And from the C1 segment, this one which is supplying the genohyoid and the thyroid. Okay. So this from this one we have a branch which is called as your descendens hypoglossi. Descendens hypoglossi. And this both are combining to form your ansa cervicalis. Can you just quickly what is it? Ansa cervicalis. Yes. Ansa cervicalis. So, this ansa cervicalis, this will supply four muscles. To be specific, three muscles, and the third muscle has two bellies. Okay, the superior belly and the inferior belly. What are the muscles? Your sternothyroid, then your sternohyoid, and superior belly of omohyoid, SBOH, and your inferior belly of omohyoid, IBOH. The answer cervicalis supplies sternothyroid, the superior belly of omohyoid, and the inferior belly of omohyoid. Talking about your this nerve it goes with the 12th nerve. The 12th nerve is lying parallel to this. And let's talk about another segment. Just join C2 and C3 and C3 and C4. So there will be two nerves given here. From the C2 segment, there will be nerve to your sternocleidomastoid. So you can remember your sternocleidomastoid is supplied by C2 nerve. These are the proprioceptive branches. These two branches I am drawing currently. This will be your proprioceptive branches which are connecting it to the spinal nerve. So you can just remember that the sternocleidomastoid is supplied by the spinal nerve and the C2 segment is contributing to it. So here is a spinal nerve. Here must be a spinal nerve. Just don't go into my color coding. It is to make you understand the things. This is your spinal nerve. Okay, and your C2 segment is joining with it, and this part is called the nerve to sternocleidomastoid, nerve to SCM. From the C2 and C3 segment, specific uh, not C2 and C3, from the C3, from a C3 and the C4 segment, like specifically, we have another nerve which is supplying the trapezius muscle. The trapezius muscle, this spearhead shaped, seal shaped muscle that is present in the back, is supplied by the C3 and C4 segments. So this are supplying your. This is called as a nerve to trapezius. So you just know now what are the deep branches where they are arising from and what they are forming. And if your superficial branches are arched, you will have to draw this diagram. And if your deep branches are arched, you have to draw this diagram. Okay. So that completes your cervical plexus. Let's move on to the next concept. Let me check what is the next concept present in your textbook. So guys, let's talk about the tongue. Let's talk about your tongue. So what is tongue? You know the tongue? Yes. The tongue has three parts. It has a root, a body, and a tip. Root of the tongue is attached posteriorly to the hyoid bone, to the mandible, and to the styloid process. The root of the tongue is attached posteriorly to these parts. So we have a root part which is attached to your hyoid bone, which is attached to your mandible and your styloid process. Then we have the tip. Tip is attached to your, not attached, it's free, but it is like related, or it is, you can say, it is present proximally to your central incisors. The tip of the tongue is present proximally to your central incisors. And you know the body of the tongue. What is the body of the tongue? Talking about this root, tip, and the body, and let's talk about what are the different parts of the tongue. What is your foramen cecum? What is the sulcus terminalis? Let's talk about these parts. Very simple parts. Tongue is a simple organ, I will say. Just you have to draw plenty of diagrams. Okay, and I will teach you in diagrammatic manner only. So let's take the tongue here. If it is the tongue, we have our sulcus terminalis. This is our sulcus terminalis, and here the meeting point of two sulcus terminalis on both sides is called as the foramen cecum. Is called as the foramen cecum. Okay, so this is the posterior one third. This is the posterior one third of the tongue, and this is the anterior two third of the tongue. This is the anterior two-third of the tongue. In the posterior part, we have a presence of lingual tonsils. Of the presence of the lingual tonsils. Do you know about Walde's ring? Walde's ring has the presence of four types of tonsils that are present in the ring format. Around the nasopharynx and the oropharynx, we have the presence of four types of tonsils which are arranged in the ring format. That is called as the Walde's rings. So here is the Walde's ring. What are the types of tonsils that are present? So first one is a pharyngeal tonsil. Pharyngeal tonsil. Then other two ones, these are your tubal tonsils. What happened again? Okay. Then we have the tubal tonsils. Tubal tonsils. Then your lingual tonsils. And your palatine tonsil. That forms a Walde's ring. Okay, that forms a Walde's ring. So what you have in a Walde's ring? We have our pharyngeal tonsil, your tubal tonsil, your palatine tonsils, and your lingual tonsil. That completes a Walde's ring. We are not going to Walde's ring. This is the other part of this chapter. So we are talking about foramen cecum, sulcus terminalis, posterior one third, anterior two third. These all parts. Afterwards, let's move on to the muscles. First, let's see the ventral and the dorsal surface of the tongue. So if you see the ventral surface, first let's see the dorsum of the tongue. Then we'll go to the ventral surface. This part is the dorsum, and this part is your ventral surface. So if you see the dorsum, this is your epiglottis. We have the lateral epiglottal folds, LGEF, lateral epiglottical folds that are two in number, and the medial glossoepiglottic fold. Medial glossoepiglottic fold, that is one in number. So and this part is called as a V. What is V? V is called the vallecula. Vallecula. V is your vallecula. Okay. V is called as a vallecula. V is your vallecula. Done. Afterwards, let's see the dorsum, how it is arranged like this. Yes. Then we have your sulcus terminalis, your foramen cecum, and some lingual tonsils are present in this posterior part. Some lingual tonsils are present. So here you can draw your lymphoid follicles that are present. Lymphoid follicles that are present. And here is the median sulcus of the tongue. This is the median sulcus of the tongue. Along this sulcus terminalis, you have the arrangement of 8 to 12 large papillae that is called the circumvallate papillae. What are they? They are your circumvallate papillae. They are 10 to 12 in number, and that's the largest of the papillae. So they are circumvallate papillae. You know about this papillae, so I'm not going into much detail. Then we have some leaf-shaped papillae. That is a foliate papillae, which is rudimentary in case of humans. So you have some foliate papillae present over here. These ones are your foliate papillae. Foliate papillae. Then we have some fungiform papillae in the anterior part, more anterior part. We have some fungiform papillae arranged like this. These are your fungiform papillae. The shape like this. It have a pedicel and a like bulged part and a top part. A mushroom shaped papillae are there, which are called as a fungiform papillae. And then we have filiform papillae distributed evenly over the dorsum of the tongue. These are your filiform papillae. So this completes your that dorsal aspect of the tongue. Okay, this part, the front part of the tongue. Let's move on to the ventral aspect, and let's see the tongue from the inside. Like we are seeing this part. Okay, this is a ventral aspect. We have a frenulum. We have a fold just filial, which is called as a lingual frenulum. Lingual frenulum. This is your lingual frenulum. or it is called as a frenulum linguae. Frenulum linguae. And if this lingual frenulum is short in some due to some genetic defects also, if this lingual frenulum it is very short, so tongue will not be able to be protrude or will come like that person is called as a tongue tied person, tongue tied. So if it is short, if short, we call it, if this short, we call it is as your ankyloglossia patient. Ankyloglossia. The patient is having ankyloglossia, that is tongue tied person is. And after this lingual frenulum, in the sides of the lingual frenulum, we have the deep lingual veins, two deep lingual veins, which are the main venous drainage. Main vein of the tongue is a deep lingual vein. This is a deep lingual vein. This is a deep lingual vein. Okay. Here we have what we have. Your openings of your Wharton's duct. Your Wharton's duct opens here in this part. This called is a sublingual papilla. Sublingual papillae are present in this part where the Wharton's duct open and they secrete the saliva. The saliva is released here. Okay, and if we have a drug called as a sorbitate, a sorbitate drug is there, which is a it is put beneath it, and then the drugs from vomiting and so which are put that beneath the tongue, and then they can directly go into your portal circulation and have effects on the body. So sorbitate, these are just drugs which can be put and can be absorbed by putting beneath the tongue. Okay, this is a like fact, just a general fact. Sublingual papillae are there. Then we have some folds here which are called as sublingual folds. Some folds in this part which are called as sublingual folds. Sublingual folds. Okay, and some you can say fimbria like structures which are present like this. Fimbria like structures which are present like this. Okay, which is called as a plicae fimbriata. Plicae fimbriata. You can see the tongue. You can see the ventral aspect of tongue and feel the like this. Okay, you can feel like this, and you can see your plicis infimbriata. You can feel this. You can feel this. If you just put a finger, this is the ventral aspect of the tongue. So this is a plicis fimbriata. That completes the different things that are present in and that are there in your tongue. Okay, like your dorsal aspect and the ventral aspect. We have to discuss more. Let's discuss about the muscles of the tongue, which is an important part. Let's discuss about the muscles of the tongue. So what we have basically, we have intrinsic muscles and the extrinsic muscles. In intrinsic muscle, if we are taking a transverse section of the tongue, we are taking a transverse section of the tongue. So what are the intrinsic muscles? Let's see. We have taken a transverse section of the tongue. So here we have the muscles like, let me make the muscles in red. Okay. This muscle is called the transverse muscle of tongue. This is your first one. That is a transverse muscle, which will make your tongue narrow. If the transverse muscle contract, the tongue will become narrow. And then we have the vertical muscles. These are your vertical muscles. And this vertical muscle are gonna make your tongue broader. If they will contract, the dorsum of the tongue, this is the dorsum. It is like this now. If the vertical muscle is present in this manner, if they contract, the tongue will become broad. Tongue will become broad and flat. So vertical muscles. This is a median sulcus, and here we have your superior longitudinal muscles. Your superior longitudinal muscles are there, and then we have your, in this part we have your inferior longitudinal muscles. Your inferior longitudinal muscles. So that completes your tongue part. That intrinsic muscles of the tongue, which are your intrinsic muscles. superior longitudinal, transverse muscle, vertical muscle, and your inferior longitudinal muscles. Let's discuss about the extrinsic muscles. What are the muscles which are coming from elsewhere? These muscles are only starting from the tongue and ending there. Okay, no attachment, no origin, and nothing. Just they are present in the tongue. They are present in the tongue, you can say. And the extrinsic muscles, they arise from somewhere and are inserted to the tongue. Arise from somewhere else, insert to the tongue. Like from palate, a muscle is coming to the tongue, palatoglossus. From a mandible, a muscle is coming to the tongue, dividing to three bands: upper band, middle band, lower band. That is called the genioglossus. From the hyoid bone, a muscle is there, your hyoglossus muscle. Your hyoglossus muscle. Okay, like that. We'll discuss about, and from the styloid process also, there's a muscle that's called as styloglossus. Okay, so the four muscles. Uh, let's talk about the extrinsic muscles in a diagram. Let me make the diagram first. Let's say here is a tongue. Here we have the palate. Here I made the hyoid bone. This is the styloid process. Let's say this is the cross section of the mandible with the teeth. Let attach a teeth. Done. So we'll see the attachments from these parts. Let's discuss how the fibers are arising. From the palate to the tongue. From the palate to the tongue, we have our palatoglossus. PG. I'm writing PG. Palatoglossus. From the mandible, there is a muscle that is arising like this. The upper band is like this. Lower band is like this. Sorry, middle band is like this. The lower band is going to the hyoid bone. This muscle, this whole muscle is called as a genioglossus. Genioglossus. And this genioglossus, just important fact is that this genioglossus muscle is called the safety muscle of the tongue. This is called the safety muscle of tongue. Safety muscle of tongue, because it is preventing the tongue from falling out. Okay, so it is called the safety muscle of the tongue. Then you have another muscle that is going like this from the hyoid bone to the tongue. This is called as a, this fibers are called as a hyoglossus. Hyoglossus. And there is a muscle which is arising from the styloid process to the tongue like this. This is called as a styloglossus. These are the intrinsic muscles of so extrinsic muscles of the tongue. Okay. So palatoglossus attaching to the root of the tongue part, and then genoglossus has this arises. This genoglossus muscle exact origin is called a It's called a superior genial tubercle of the mandible. It's called as a superior genial tubercle of the mandible. It originates from the superior genial tubercle. It has an upper band. It has a middle band, and it has a lower band, and attaching to various locations. This upper band is attaching to this body of the tongue. This middle band is going and merging with the hyoglossus muscle. This lower band is attaching to the hyoid bone. It's attaching to the hyoid bone. So these are the muscles, and you can easily see the action. Like for example, let's take hyoglossus. What will hyoglossus do? If it will contract, it will contract. The hyoglossus will make the dorsum. The dorsum is like that. There is a hyoglossus present beneath it. If the dorsum the tongue, if it contracts, this muscle contracts. What will do? It will pull the tongue like this. It will pull the tongue like this, make the dorsum the tongue convex. So this hyoglossus muscle, it will make the dorsum convex. It will make the dorsum the tongue convex. This genioglossus again, upper band, what will do? It has three functions. This genioglossus, says upper band has another function, the middle band has another function, the lower band has another function. So it is having three functions. Okay, the upper band, what will the upper band do? You can remember the mnemonic RDP. RDP. You can just see from this structure, you can just correlate how will be the movement occurring and imagining for those who are just ratifying the things. Of course, I will not encourage you to ratify the things, but it has a mnemonic like RDP. What is RDP? Your upper band, lower band in your middle band in the lower band. So R is the retraction of the tongue, retraction of tongue. D is the depression of tongue, and P is the protrusion of tongue. P is the protrusion of tongue. So these are your actions of your that muscle, which is a genioglossus muscle. And hyoglossus muscle we like discussed. Styloglossus, what will it do? If it will like contract, if it will contract in this direction, then it will pull the tongue back. It will pull the tongue back. That is the retraction of the tongue. So it has also the function of the retraction. And palatoglossus, it will just, if it contract, it will elevate the tongue like this. Okay, this is the action of a palatoglossus in which the your lingulum flare is stretching. Okay, so this these are all about your extrinsic muscles. And like we've finished this, and now let's go on to, let's say, we have to discuss the arterial supply. Let's discuss the arterial supply of the tongue. About the nervous drainage of the tongue is supplied by four nerves. That is your fifth nerve. Okay, that is the fifth nerve. Your ninth nerve, fifth, seventh, ninth nerve, fifth nerve, seventh nerve, ninth nerve, and the tenth nerve. Fifth nerve is that it is like the branch is a lingual nerve. Seventh nerve is the cauda tympani nerve, which you'll see in the course of the facial nerve. This is the cauda tympani nerve. Ninth nerve is there, and the tenth nerve is a recurrent, is a internal laryngeal nerve. Okay, internal laryngeal nerve, ILN. That is your tenth nerve, a branch of your tenth nerve. So this four nerves are generally supplying the tongue. Four nerves are generally supplying the tongue. All the muscles of tongue, all the muscles. Note that all the muscles, all the muscles, all the muscles of the tongue are supplied. All the muscles of the tongue are supplied by the twelfth nerve. Are supplied by the twelfth nerve. Supplied by the twelfth nerve. But except which muscle? Your palatoglossus. Palatoglossus, and this palatoglossus is supplied by the tenth nerve, or a vagal accessory complex, your VAC, vago accessory complex, or your tenth nerve. Okay, so palatoglossus is supplied by the tenth nerve or your vago accessory complex. Except. So this is a very important fact. It is often asked in a viva. Let's discuss the arterial supply without much delay. This is the tongue. You know about the common carotid artery. Common carotid artery, the CCA. This divides into internal carotid and external carotid. We have an internal carotid artery which will be going towards the brain, and external carotid artery is mainly supplying the tongue. So this is the external carotid artery, ECA. ECA is the external carotid artery, this one. And how it is giving branches to the tongue? That external carotid artery, a branch from the external carotid artery is called as a lingual artery. Is called as a lingual artery. Here is a lingual artery. This is a lingual artery. And this lingual artery is dividing into deep lingual artery and two dorsal lingual arteries. It is your, this is continuing as the deep lingual artery, and two other branches are called as the the dorsal lingual artery. Dorsal lingual arteries. Then we have your facial artery. Your facial artery is also supplying your tongue. Your facial artery is also supplying your tongue. We have our tortuous nature. That's tortuous nature facial artery. Not exactly a facial artery. It has a tonsillar branch. It has a tonsillar branch of facial artery, which is generally supplying your tongue. We have a tonsillar branch. This is a tonsillar branch of facial artery, which is supplying the tongue. Tonsillar branch of facial artery is supplying your tongue. So this completes the arterial supply of the tongue. You know about the venous drainage. Venous drainage, I said. If I haven't, let me state the venous drainage. Your venous drainage is by two veins, that two parts. Two parts you can say. One is your deep lingual vein. Deep lingual vein, which is the main part. We saw the deep lingual in the ventral aspect, and then we have another one is a veni comitatus. This is the complex which is supplying the tongue, and it is forming an accessory part. After this, We completed the arterial supply, we completed the muscles, the nerve supply, the venous drainage, and intrinsic muscles, dorsal aspect, ventral aspect of the tongue. Probably completed all. Just an important clinical fact: if there is 12th nerve palsy in the right side, then ask the patient to protrude the tongue. The tongue will deviate towards the right side. Right deviation of tongue. Right deviation of tongue will occur. Okay, this is just a diagnostic feature. We know about the ankylosing. You can write in clinicals. At this point, you can add in your clinicals part, and you can write about the ankylosing. You can also write about the sorbitate point which I told, and you can just give an introduction to your glossitis. Glossitis is the inflammation. Glossitis is the inflammation of tongue. It is many types of squamosal glossitis or cuboidal glossitis. Many times so that these squamous glossitis and all. So we are not going to much details. So you can just add this glossitis point, this palsy point, and we are great to go. We are great to go. So let's move on to the next part. Let's move on to a next concept. Let's move on to the next concept. That is, if you want to know the muscles of the face, sometimes they are asked the muscles of the face, your orbicularis oculi muscles, your procerus, and your rhizorius and your LLSN muscle. So you can just get an introduction of the muscles of the face. If I just we're not gonna make the face like this. Let's make it oval. This is the face. These are let me draw the eyes like this. Okay, so it's basically a robot. You can draw the eyes circular. It will be better. And let's draw your nose like this, your mouth like this. This is your face. So we are discussing about the muscles of face, that are muscles of your facial expression, muscles of your facial expression. So first, there is an important part that is called as a first muscle is called as a buccinator muscle. Buccinator. So what is the buccinator muscle doing? It is helping blowing like this and whistling. You're whistling. So a muscle is present in this part which is called as a buccinator. Buccinator, which is your blowing muscle or your whistling muscle. Blowing muscle or your whistling muscle. So if you're blowing or whistling, you require your buccinator muscle. Then what muscle you have? For the transverse wrinkling, like this. Like you must have seen the famous personalities, the famous figures, they have transverse wrinkles on their face. So which muscle is doing this transverse wrinkles? This muscle is your procerus, like this. Procerus. So when the procerus will contract, it will cause a transverse wrinkling of the face. Okay. Then what muscle we have? We have here these two muscles which are called as the orbicularis oculi. Orbicularis oculi. And this orbicularis oculi is generally helping in the closing of eye. It is helping in the closing of eye. If you are just closing your eye, it is the action of your orbicularis oculi. Okay. Then here, what other muscles you have here? We have a transverse muscle present in the mouth like this here, present like this, and this is your rhizorius. Rhizorius is called the grinning muscle. Grinning muscle. Rhizorius is called the grinning muscle. Like you do like this. This is a grinning muscle. It is pulling the mouth like this. This is a rhizorius. And other muscles like your this one around the mouth. This is called the orbicularis oris. Orbicularis oris. There is a muscle which is arising from here, this margin, and is going all the way down to your upper lips. Arising here, going all the way down to your upper lips, like this. Something like this. This muscle is called as your levator labii superioris aliquinesi. It is called as a levator labii superioris aliquinesi. It's a long name. It's the longest name of given to a muscle. Okay, seems interesting. So it is called the LLSN. I'm just writing LLSN. Levator labii superioris aliquinesi. So what it is doing? It is LLSN. Levator labii. That is, it is elevating the lip. Which lip? Superioris. That is the upper lip. This levator labii superioris means elevating the upper lip, and it's like it's running along the ala of the nose. It's running in the ala of the nose. Okay, so it has these actions. Levator labii superioris aliquinesi is there in the face. Then what we have, another muscles which are present in the face, that is your, let's draw. Yes, here is a muscle present. Here is a muscle present in the chin. This is called as your mentalis. And what is this mentalis doing? This mentalis muscle is causing a wrinkling of the chin. This is causing wrinkling of the chin, so as to produce a confused expression. Okay, so you're producing a confused expression. So you're producing a confused expression. So this is called causing wrinkling of the chin. Then let's move on and talk about some other muscles which are present. So you can have other muscles. Other muscles are also present, like you have a muscle here. Just look at this. You have a muscle here. This muscle is called as a levator labii superioris only. It is not dilating the nostrils. That is, it is not called as a aliquinism. It is only a levator labii superioris, LLS. And we have the levator labii superioris in this region also. Then we have a muscle just laterally to a levator labii superioris, that is called as a zygomaticus minor. What is this zygomaticus minor doing? It is, what it is doing, it is elevating the upper lip. 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 And then what? Another muscle, that is a zygomaticus major. What is this zygomaticus major doing? It is also like action is the same, but what it is doing, it is called as a smiling muscle. You are smiling like this. So it is the action of a zygomaticus major. It's called as a smiling muscle or smiling expression. Okay. Then we have some muscle like this. This is called as a compressor nasi. A muscle present here causing a corrugation like this. You are doing like this. This is a corrugator. So it is called as a, this type of muscle. It's called as a corrugator supercilii. Corrugator supercilii muscle. Corrugator supercilii muscle. Then what other muscle you have? Like for example, you have a muscle present here and a muscle present here. This muscle, let me mark with some other color or else you'll be confused. This muscle. This muscle is called as a levator. This is called as a levator labii. Levator labii angularis. That is angular in structure. Angularis. Levator labii angularis. Understood? And it's present just you can just imagine it is present beneath your zygomaticus muscles. Okay, it is going like this, and zygomatic muscles are just covering the face. We'll see in the 3D. Okay, we are gonna get an orientation in 3D too. So this is a levator labii angularis. Levator labii angularis. After that, we have our these two muscles. These two muscles are present in this region. In this region. What it will do? It will, when it will contract, the mouth will be like that. Sad expression. Sad expression. So these two muscles are producing sad expression. These muscles are called as your depressor labii inferioris. Depressor labii inferioris, which are producing a sad expression. Okay, so this is for your sadness. So I have discussed all the muscles which are present, all the muscles which are present in your face. This completes all the muscles and the actions of these muscles, how they are helping in what manner. Okay. Now let us try to correlate the muscles in a 3D orientation. Let us try to correlate the muscle in a 3D orientation. Okay. So here is the face. Here we have shown your face, and here is our 3D model showing all the muscles. And let's discuss which muscles are what. So can you identify this muscle, this present mouth like this? Yes, your orbicularis. You have your, why is the pointer not working? Just a minute. Yes, your orbicularis oris. This one is your orbicularis oris, and this one. This one is called as a zygomaticus major. Can you identify this zygomaticus major? This one is the zygomaticus major. And beneath the zygomaticus major, just medial to the zygomaticus major, is the zygomaticus minor. This one I am not able. Yes, this one is a zygomaticus minor. Then, uh, just then after to the medial side of the zygomaticus minor, we have our levator labii superioris. Our levator labii superioris. Okay, we have our levator labii superioris. Let's isolate the muscles which you are doing. So we have seen your zygomaticus major. We have completed zygomaticus major, zygomaticus minor. So let me like hide the muscle, and this is your zygomaticus major. Is it's also hidden, and this levator labii superioris. It is also, let's hide the muscle, and this one is a levator anguli oris. Just I said levator anguli oris is lying deep to the zygomaticus major and the minor muscle, so you're hiding this also. The transverse muscle which is used for greening is your rhizorius. This one is the rhizorius, so you're hiding this also. Let's hide the orbicularis oris. This is also hidden. You can see the teeth like this, seeming funny. And here we have the masseter muscle. The masseter muscle, it's a muscle for mastication. We're gonna talk about the muscles of mastication later. Okay, we're gonna talk about the muscles of mastication. If you can, if you want to just see the masseter muscle, how it is going, how the fibers are going. I'm isolating this. This is a masseter muscle. This you can see is a masseter muscle. The bands of the masseter muscle are there. So we'll see about that. Let us hide the muscle first. And your rhizorius muscle which is for your greening. Actually, what happened is we're isolating this. No, so I'll hide. We're hiding these all muscles also. Yes. Just see the nose. Just see the nose. There is a muscle here which is called as your, here. This one is called as your nasalis. That is a compressor nasi muscle. Same nasalis and compressor nasi. These are same. You can hide this also. And another one. So we have talked about the nasalis, and these are the orbicularis oculi muscle. You can see in the eye that are surrounding the eye. That is the orbicularis oculi that's surrounding the orbits. Let us hide this also. Just hide this also. We'll discuss about the muscles of eye when we'll come for the muscles of eye, your superior oblique, your inferior oblique. We'll discuss about that. Uh, then we have your, just see this muscle above. This is a epicranius muscle. Epicranius muscle is just surrounding your cranium. Okay, this is called the epicranius muscle. This muscle in the side, this in the temporal side, we have the temporalis muscle. This is your temporalis. Just see. Actually, I'm not able to point the things here. The app is not working well. This is a temporalis muscle present the this part. Okay, temporalis muscle present the side. We are hiding this also. This is the superior auricular muscle. This we are hiding. We don't need this. This is auricularis anterior. We are hiding this also. And the muscles of the neck. This big muscle. You can see this big muscle. This one. Just let me point first. Otherwise, how will know which muscle I'm talking about? Yes, this one. This one is a big muscle which is covering the whole major part of the neck. This is called as a platysma muscle. This is called as a platysma muscle. We are hiding this also, and here also have the platysma. Let's hide this. And here are the muscles of the neck. Here are the all the muscles of the neck that are there. Okay, this muscle. The app is not working well, really. Yes, this is a sternocleidomastoid. Sternocleidomastoid is like this. And remember, we talked when we talked about the cervical plexus, it is supplied by a spinal accessory nerve, with exine nerve, and your nerve to sternocleidomastoid is was a nerve arising from the C2 segment. It's a deep branch of the cervical plexus, which is a sternocleidomastoid. Other muscle, if I want to discuss, you have this one, which is your depressor septi nasi muscle. Yeah, the names are, you can just get confused with the names. Okay, as in Indian context and in foreign context, the names are like otherwise. Then this muscle is a buccinator. Buccinator, remember, we were calling it blowing muscle or whistling muscle. So this is the buccinator muscle. We're hiding this also. This is a depressor anguli oris. We remember we talked about muscle that produces sad expression. This is a depressor anguli oris muscle. We are hiding this, and then this type of muscle present in this part. Just- Yes, this one. Remember we talked about the muscle here. This is called a mentalis muscle, producing your confused expression in the chin. And this is depressor anguli oris again. This is a mentalis again of other side. Okay. So these were the face muscles. Yes, procerus and other ones are also visible. Let me show you this one. This one is a procerus muscle, like this, present like this, and it will do the transverse wrinkling of the face. It will do the transverse wrinkling. And present above, this is a corrugator supercilii muscles. We're hiding this also. That So we have discussed this much muscles, okay, of the facial expression. Let's move on to the next concept. Let's move on to the next part of this chapter. Okay. So I guess guys, that's all. We should keep the lecture short and crisp, and I have a few works to do. So we'll continue this anatomy marathon in our later times. Okay. We'll discuss on the topics. So what we covered today, let me give you an overview. So we basically have covered in this chapter, we have basically covered the scalp. We have talked about the cervical plexus. After talking about the cervical plexus, we went to the tongue part, I guess. Tongue and the facial muscles. So these were the four topics which we covered in this video, and I hope you understood all the topics as I tried switch on my video camera, tried switching on my video camera and teaching you, and I taught you in written format, not as I uh, in your PPT format, but as it is a marathon, so it will be better if we like learn from the PPT format, because we are not able to cover a lot of the topics. We have in a marathon, what you have to do is to cover as much topics, as much knowledge as you can gain from a thing. So as you know, it takes, as you can understand also, it takes time to write and teach you. It takes a lot of time, in fact, to write and make you understand all the things, but of course it is efficient. So what we'll do in your continuing part, in our subsequent parts, we'll not cover all this will not cover all these topics, but we'll just superficially grasp through the topics. We'll superficially go through these topics quickly, very quickly, and then we'll continue the marathon and do the rest of the topics that are in your head and neck, and from the PPT, or you can say PDF form. Okay, so that's all, guys. I hope you enjoyed the lecture. I hope you could connect with me. You could see all the concept. You could visualize the things. For more such lectures, you do subscribe to my channel, and do like, share, and subscribe. Let's meet again in any other video. That's all. Thank you. Goodbye.